Welcome back. New week, new topic, new module. We're doing module 2 starting today. So, this week's discussion will center around a relatively common complaint in the general population, which is dizziness. Once again, the learning outcomes would include defining the term dizziness, list of various diagnostic triads that are related to the different varieties or causes of dizziness. Describe the key features of each of these diseases covered in the diagnostic triads. Review the labs mentioned and review the significance of physical signs that are mentioned that are related to the physical signs that are mentioned. So, our index patient is Joanna Sicalot, the younger sister of Brian, and she is complaining of dizziness with blackouts. Now let's define the word dizziness. Dizziness is defined as a feeling of being unbalanced or lightheaded. This feeling of unbalance or lightheadedness could be expressed as a sensation of spinning around or losing one's balance, or sometimes the term there's a sense of disorientation in space or feeling woozy. There are four types of dizziness based on the description by the patient. So listen carefully to what the patient says when they describe their dizziness. If they say the room is spinning around me, the proper word for that is vertigo. They may or may not use the term vertigo. If they use the word vertigo, have them describe exactly how does vertigo feels, because sometimes the vertigo is not that the room is spinning. They feel unsteady as if they might be spinning. And that's a different term. That is disequilibrium. I feel unsteady. The third type of dizziness is lightheadedness. They may use the word I feel woozy. And then the fourth is pre-syncope. Now, they're not going to tell you when you ask them what's wrong with you, they're not going to tell you, Doc, I feel pre-syncope or pre-syncopic. They more likely to describe I need to lie down or sit down or else I will pass out. Have you ever passed out? No, because passing out is a totally different symptom that is called syncope, and we're not going to be discussing syncope in this course, but we'll be discussing pre-syncope. I feel I need to sit or lie down or else I would pass out. So with those four types of dizziness, we have four main hubs or diagnostic triads to discuss. Any questions before we go into the very next one, which happens to be vertigo? Remember, vertigo is the term in which the patient is saying the room is spinning around me. The first of three common or important causes of vertigo is benign paroxysmal positional vertigo, or BPPV for short. This is a benign condition. It's not going to worsen. It will pass and maybe recur again. Paroxysmal means comes on episodically all of a sudden. Positional implies that it might be triggered by a change in the position of the head, and vertigo, the patient will complain that the room is spinning. This is an inner ear disorder. The actual cause of this is unknown. We think it might be degenerative because it tends to occur more in the older population. And the classic clinical picture is severe episodic vertigo that is triggered by a change in head position. If you were to examine the patient while they're having one of these episodes, you will see their eyes moving, usually from side to side, left to right, right to left, very rarely in the vertical position. The Dixie Hall Pike maneuver is going to be diagnostic. I am not going to test you on the actual steps in the Dix-Hallpike maneuver, but this will be tested in the form of, if you have a patient whose complaint is this, which test is diagnostic? Is it the Dix-Hallpike? Is it the Bocody? Is it the Romberg? Or is it the pass pointing test? But it involves you're placing the patient at a 45-degree angle, having them lie backwards on the examination table with their head hanging off of the table, looking in the direction of you, and then see if that triggers the side to side movement of the eyes, nystagmus. If facing you does not trigger this, then go over on the other side and repeat the Dix-Hallpike maneuver. No labs are necessary to confirm this diagnosis. This diagnosis is made on a good history and the physical examination finding with the Dix-Hallpike maneuver. Treatment would be the Epley maneuver. Once again, I am not going to test you on the various steps in the Epley maneuver. I will test you which of the following is most helpful from a chiropractic perspective in a patient who presents with signs and symptoms, and you're going to have to make the diagnosis of benign paroxysmal positional vertigo based on the information you will get in the clinical vignette. However, this is testable in boards part 4. In boards part 4, you're likely to get a simulated standardized patient who will complain of symptoms typical of BPPV, and then they will ask you what specific tests would you like to do at this stage. You choose the Dix-Hallpike. You go next door to the post-encounter probe, and they said based on the patient's history and finding in the previous station, what do you think is the diagnosis, which labs are necessary, and which is the best treatment? And they will offer you a variety of maneuvers or treatment procedures, and you should be able to identify that it's the Epley maneuver. And then you have to go through the process of having the patient sit on the bed and place a pillow behind them. This is something you can actually teach your patient too. So you need to demonstrate this in the office, have them repeat it, and then go home in case this thing comes back, because it has a tendency of coming back every now and again. The patient's head would be turned 45 degrees to the right, so facing you if you are standing on the right side of the patient, and you quickly have the patient lie back with the shoulders on the pillow, therefore the head is slightly below, resting on the bed for 30 seconds, and then without raising their head, you have them turn to the left 90 degrees, wait for another 30 seconds, and then quickly have the patient sit up and stay in that position for 30 seconds. And then they bring their head back in the central position, and you can either repeat this 3 times or have the patient repeat this 3 times until they get daily relief. The underlying pathophysiology is that the little stones that are found embedded in the copula of the crista ampullaris gets displaced off of the top. They fall down, usually into the posterior semicircular canal, and then this triggers the severe vertigo. And this maneuver, the Epley maneuver, is trying to reposition the fallen otoconia, is what these little stones, or otoliths, these stones are called, back into position, or at least off of the posterior semicircular canal. Okay. The next condition, which is not as common as BPPV, is vestibular neuronitis. So you can see in the term, this is an inflammation-itis of the neuron, the nerve. Which nerve? The vestibular part of the vestibular cochlear nerve, cranial nerve 8. So it's an inflammation of cranial nerve 8, usually by a variety of herpes viruses. It could be type 1 or type 2, or occasionally it might be seen caused by the Borrelia spirochete that causes Lyme disease, because one of the uncommon neurological manifestations of stage 2 Lyme disease is neuronitis. You can get a neuronitis affecting the facial nerve and the facial canal, and therefore Bell's palsy would be a presentation. Sometimes it is the vestibular cochlear nerve, as it is in the internal acoustic meatus, that gets inflamed. The clinical picture is classic sudden onset of severe vertigo and nystagmus. Once again, there are no labs that are necessary to make this diagnosis, and you refer this patient to an ENT specialist who will want to confirm the diagnosis and then do various procedures that are outside the scope of a regular chiropractor. Now, a chiropractor trained in neurology might be able to do vestibular nerve rehabilitation or other procedures to help the body restore the imbalance. And the third, Meniere's disease, is a disease that is characterized by three main triads: vertigo, tinnitus, deafness. Vertigo, the room is spinning. Tinnitus, it usually is a high pitched noise in the ear that is affected. This might be unilateral or bilateral. And then there's progressive deafness, as this is a recurrent problem for the next couple of years. It is due to an increase amount of fluid in the inner ear, but we do not know what causes this. Patients with Meniere's disease will present with recurrent episodes of vertigo, tinnitus, increased deafness, and nystagmus. Once again, no labs are needed to make the diagnosis. Refer the patient to the ENT specialist, who, after confirming the diagnosis, has several options available. One is to put the patient on a probable low salt diet. There's been some evidence that a low salt diet helps reduce the amount of fluid in the inner ear. The ENT specialist has access to drugs that are anti-vertigo drugs and other modalities to help treat this condition, which, if not treated, is going to lead to progressive deafness. Any questions? So that's the first of four diagnostic hubs. The second hub is pre-syncope. Remember, pre-syncope is a feeling of, I'm going to faint if I don't sit or lie down right now. And one uncommon cause is hypoglycemia. Hypoglycemia is defined as having a random blood sugar less than 70 milligrams per deciliter. The most common cause of hypoglycemia is overtreatment of diabetes, where the patient takes the medication, takes their injection, forgets to have a meal, rushes off for an important meeting, and then gets confused and disoriented in the meeting. A rare cause is a condition called insulinoma. So let's look at the word insulinoma. It is ending in oma. It's not one of the 5 or 6 exceptions to the OMA rule. So this OMA means this is a benign tumor. This is a benign tumor that causes increased amounts of insulin to be secreted by the beta cells in the islets of Langerhans. The insulin is increased in spurts, and whenever there is an increase in the insulin that is released from these benign tumors, the blood pressure is going to, it's not the blood pressure, the blood sugar is going to drop. There are going to be symptoms of hypoglycemia, which are sweating, palpitation, tachycardia, sweating, palpitations, tachycardia are signs of sympathetic hyperactivity because one of the hormones that is produced in this very stressful condition is norepinephrine, otherwise known as noradrenaline. Is going to try and get as much sugar into the system when released, and therefore excess norepinephrine is going to trigger the sweat glands, is going to trigger the SA and AV node in the heart. That's going to cause a tachycardia. That tachycardia will be perceived by the patient as thumping, beating in the chest. If this is ignored, the patient is going to be confused. They're going to lose their train of thought. And if not, if they're by themselves, they're going to slip into coma and not recover from this. There's a triad associated with insulinoma. Does anybody remember the name of this triad from trimester 4 when you did gastrointestinal pathology? If you said Whipple's triad, you would be correct. Whipple's triad, three things. The first is symptoms of hypoglycemia: sweating, palpitations, tachycardia, confusion. The second in the triad is documented low sugar in the blood. If you have access to a glucometer and you test the blood, it must be, to meet the diagnosis, less than the random blood sugar, should be less than 70 milligrams per deciliter. And the third part of Whipple's triad is having recognized that the symptoms are due to hypoglycemia, having confirmed that hypoglycemia is present, then giving the patient, while you call 911, tea that has 10 teaspoons of sugar dissolved in this, and over the next 5 minutes, the patient should start to come out of that hypoglycemic state. Management for this: if you suspect this, you call 911, unless you have the possibility, the wherewithal to test the blood in your office. In my practice back in South Africa and the rest of the world, I had a glucometer with test strips that I got from the pharmacy, and I have been able to diagnose, in fact, here on campus many years ago, two persons. One was a student and the other was a librarian, and both of them wore silver bracelets that identified them as diabetics, and I was able to interpret the confusion, the tachycardia, and the bracelet, the diabetic bracelet, as you have hypoglycemia, sit you down, drink this, and within 5 minutes, they were both out of the situation. There is if you have the test material, glucometer, and the test strips, then test the blood and you apply the 15-15 rule. The 15-15 rule is 1, test the blood glucose. If the blood glucose is less than 70 milligrams per deciliter, have the patient drink or eat 15 grams of fast-acting carbs or sugar, and then wait 50 minutes to see what happens. And you repeat the blood sugar in 5 minutes to see if the blood sugar is coming up. If the blood sugar is not coming up, then you call 911. If not, you're calling 911. In the ambulance, the emergency medical technicians have the equipment to test for hypoglycemia, and they can correct this immediately. Okay. The next cause of pre-syncope is orthostatic hypotension. Orthostatic means is really related to being in a lying down position for a while, and then when you attempt to stand up or sit up, you kind of feel lightheaded. You have to lie back down until this passes. So the definition of orthostatic hypotension is a drop in the diastolic blood pressure greater than 10 millimeters of mercury going from sitting to standing, taken 3 minutes after the change in the position. Common causes are patient is hypertensive, is on blood pressure medication. A non-common cause, but common during uh, summertime when uh, the temperatures are up, they are not hydrating regularly. This could cause orthostatic hypertension. The clinical picture is a decrease in the BP standing compared to previous lying or sitting. It's either greater than 20 millimeters of the systolic pressure or greater than 10 millimeters of the diastolic pressure. Now, orthostatic hypertension is different from POTS. POTS is the acronym for paroxysmal orthostatic tachycardia syndrome. So POTS will not occur with changes of position going from lying to standing or sitting to standing. POTS occurs suddenly, hence the term paroxysmal. Orthostatic, it has to do with uh, a change in position, but not triggered by a change in position. And then we will talk or could talk about that later if you're interested, but it's not part of this discussion. But what is specific in POTS, paroxysmal or orthostatic tachycardia, there's a rapid increase in the blood pressure. It's due to a sympathetic dysfunction, and you need to, from a chiropractic perspective, adjust, usually upper cervical, trying to stimulate the parasympathetic to dampen down the overactivity in the sympathetic system. Measure that blood pressure. If that blood pressure is less than 90/60 systolic over diastolic, call 911 because there might be a reason for this. It might not be BP meds like thiazide diuretic or beta blockers or calcium channel blockers or ACE inhibitors. It might not be due to dehydration. It might be a signal of there is an internal bleeding, usually in the abdomen. If the blood pressure has not dropped to below 90/60, this is not a 911 call. You refer the patient if the patient is taking blood pressure lowering medicines and have the medical doctor reevaluate this patient and probably change them to another hypertensive med, which is not known for its powerful hypotensive side effect. And the last in the cause of presyncope is vasovagal syncope, um, in which the patient actually passes out. Vasovagal sympathy is defined as a sudden loss of consciousness due to a drop in the blood pressure and the heart rate. This is due to hyperactivity of the parasympathetic system. This is why the heart rate is slow, not rapid. Causes of vasovagal syncope is prolonged standing. Soldiers on guard outside Buckingham Palace in the days gone by were known to stand erect, not moving, no matter what silly face you would make in front of them, hoping that they would laugh or giggle. Sometimes they would just stand there and then all of a sudden drop, still at arms together, feet together, they drop flat on their face. The sight of blood, so emotional stress like the sight of blood, fear, heat exposure can also cause or trigger a vasovagal sympathy. Sometimes you're not aware of this, and then you just wake up with a bump on your head and you're wondering what happened. Did I get mugged? I didn't check my back pocket, check for my phone, it's all there. And then you should be worried. You go off to see the doctor. Clinical picture: sudden onset of lightheadedness, nausea, blurred vision, cold sweat. And if they don't get to sit down or lie down, As they begin to feel this and it comes on them suddenly, they would then lose consciousness, and that would be the syncopic presentation. Once again, no labs are necessary. Management at the site of the occurrences raise the feet of the patient above the head, so they'll be lying down and remove the trigger. So if taking blood triggers this, um, take off the tourniquet, revive the patient, and do whatever you have to do. So there's a prodrome, and a prodrome, if you look at the figure down at the bottom on the right, a prodrome is what you're going to get before they actually faint away. Dizziness, lightheadedness, sense of being warm or cold, nausea, sweating, palpitation, uh, blurred vision. They may complain of blackouts and hearing changes. That stuff just sounds absolutely quiet. What is going on? And then they find themselves in this particular situation. As I said, it's due to activation of the parasympathetic system, in particular the vagus, that acts on the heart rate and the vessel wall. Blood vessels are going to vasodilate rapidly. The heart rate is going to drop. And if you remember that formula from physiology, blood pressure is the product of stroke volume times heart rate times peripheral resistance. If both your peripheral resistance and your heart rate is dropping, then your blood pressure is going to drop precipitously and then cause you to faint. Any questions? The third of the four diagnostic hubs is disequilibrium. This is a fancy way of saying unsteady, unbalanced. The first is cervicogenic dizziness. Sometimes some books would refer to this as cervicogenic vertigo, which is a misnomer as such. Dizziness is defined as dizziness related to cervical musculoskeletal issues. It may or may not follow a hyperextension neck injury. It could occur in older people suffering from cervical spondylosis, which may affect the blood flow through the vertebral artery into the brainstem. Clinical picture is dizziness triggered by holding the neck in a particular position. When you examine the patient with the head held in that particular position, muscles on that particular side would be in spasm, and when you attempt to move the patient in that direction, there's going to be a decreased cervical range of movement. The muscle spasm is an attempt by the body, the innate, to not trigger the dizziness. Labs, like most of the other diseases we have talked about in this particular complaint, are not necessary. The diagnosis is based on the history and the physical findings. Cervicogenic dizziness is very well treated by chiropractic care. You examine the patient if there's a concomitant subluxation in the region, usually mid-cervical, then an adjustment is going to be helpful. Now, you need to be careful if this is a younger patient between the ages of 25 and 45 complaining of dizziness, because it might be the beginning of a vertebral artery dissection, and you do not want to be adjusting the neck in any particular way in case the dissection continues and concomitantly or coincidentally you adjusted the patient in the spirit and the patient goes home or within the next half an hour has a stroke and they're going to blame you. So be very careful. There are a couple of D's and N's that you should have learned, that should you have dizziness associated or dizziness with diplopia, double vision, or dysarthria, or any other form of disequilibrium, and either nystagmus or nausea or numbness somewhere in the body, 4Ds and 3Ns. If you have any of these, stop. Consider the possibility of vertebral artery dissection and then refer the patient urgently off to the hospital with the diagnosis query vertebral artery dissection, and then make a note patient has not been adjusted. If not, if you don't have any of the uh, dissection, arterial dissection uh, signs, then you can comfortably adjust this patient with a chiropractic adjustment that is appropriate for the condition. Another cause of disequilibrium is multiple sclerosis. Multiple sclerosis is a progressive demyelinating disease, the cause of which is still unknown, but there is more evidence that is being gathered to support a link between multiple sclerosis now with a previous episode of HHV type 4 stroke Epstein-Barr virus link. Usually, these patients might have contracted the virus and develop infectious mononucleosis as a teen, and 10 years later present with multiple sclerosis. Multiple sclerosis, as you remember, has a tendency of affecting females more than males, and patients of a northern European extract. They're usually blonde and fair skin. Um, Classical picture: sudden loss of vision. Charcot's triad, which is classic for multiple sclerosis, is not a very common presentation, but when you see this, on boards will want you to remember what are the three things in Charcot's triad, and this would be scanning, speech intention, tremor, and the presence of nystagmus. And what I am doing right now is talking as if I am suffering from multiple sclerosis, and I'm actually demonstrating what scanning speech actually sounds like. They take every single syllable and separate it when they are talking to you. So this is very diagnostic if you had a patient with scanning speech. Intention tremor, you test them by doing the pass pointing, and there would be no tremor at rest. And when they start to do the procedure, the finger would be shaking. And obviously, nystagmus, you're going to have them look straight at you and without moving the head. Have them follow your finger off to the right and then come over back to the middle, follow the finger over to the left, and moving it into the right or left extremes may trigger horizontal nystagmus. Remember that vertical nystagmus is not as common as horizontal, and if you're going to want to do the same, having the patient follow your finger up, back to the middle, follow your finger down, and see if any of those movements trigger vertical nystagmus. The diagnosis is clinched with taking in either an MRI of the brain or MRI of the spine, depending on what the neurological presentation is. What you're looking for in the brain is periventricular plaques. The arrows, the four arrows, they show areas of gliosis, replacement of neurons and axons with fibrous tissue, forming what are known as Dawson's fingers arranged around the ventricles. You have a similar arrangement of glial plaques around the tube in the spinal cord that contains CSF, which is around the central canal of the spinal cord. Should you suspect multiple sclerosis, refer the patient off to a neurologist, whether it be a chiropractic neurologist or a medical neurologist. There are certain nutritional, dietary changes. There are certain exercises that one can use to help treat this from a chiropractic perspective. And then the other cause of disequilibriums, unsteadiness, is an acoustic neuroma. An acoustic neuroma is a benign tumor in the cranial nerve 8 is actually a benign tumor of the vestibular part of cranial nerve 8. The cause is unknown. We've been back and forth for the last 30 plus years since the invention of cell phones. Some decades, there is more evidence to suggest that chronic use of cell phones and microwave transmissions is linked to this, and other decades, no, it's not. So right now, we're not too sure. Um, Clinical picture of your acoustic neuroma is characteristic progressive deafness in that ear, along with ipsilateral facial palsy. This is again a lower motor neuron palsy, but it cannot be called Bell's palsy because it is not involving the facial nerve as it passes through the facial canal. This involves the facial nerve as it passes through the internal acoustic meatus along with the vestibular cochlear nerve and the nervus intermedius and the labyrinthine artery. So there's going to be facial weakness, unilateral on the same side with the deafness, with dizziness. Now, how are you going to tell whether the facial weakness that presents in this patient is not Bell's palsy? Now, remember in Bell's palsy, and I'm not doing Bell's palsy here as part of the testable material, but you're going to get tested in neuromuscular skeletal part of your part 2. But Bell's palsy is unilateral facial weakness associated with hyperacusis. Normal sounds would sound louder than normal. In this patient with unilateral weakness looking like Bell's palsy, the hearing would be going in the opposite direction, not hyperacusis, but hypoacusis, and then eventual permanent deafness if not taken care of properly. The diagnosis is clinched by ordering an MRI. This is an MRI T1. The water surrounding the brain is black, and there is this slightly spherical, but borders are irregular, mass growing inside the left internal acoustic meatus. Should you make the diagnosis of a patient with acoustic neuroma, refer to an ENT specialist who will then determine what is happening, what degree of damage to the cranial nerve number 8, because there are two main options, or perhaps three. Watch and wait and see what happens, because these are slow growing tumors. Try to reduce the size of the tumor with external radiation beams, followed perhaps by surgery going into the temporal bone and taking out this particular tumor. And that's a very complicated procedure that is usually done by the neurosurgeons and not an ENT specialist. Any questions? If there are no questions, let's look at the next diagnostic hub. This is the diagnostic hub characterized by the complaint of lightheadedness. I feel woozy. General anxiety is one of the common causes of patients complaining of lightheadedness. GAD, general anxiety disorder, is characterized by excessive worry. It's a mental health condition, and there's specific DSM-5 criteria that you should have learned when you did mental health previously. The cause is unknown. Here is the DSM-5 criteria. Excessive anxiety and worrying about various events having occurred more days than not for at least 6 months. So there's a 6-month duration. The patient finds it difficult to control the worry. The anxiety and the worry are associated with at least three of the following six symptoms. Only one symptom is required for a child, but in an adult, here are the six symptoms: restlessness, one, or a feeling of being keyed up or on edge, being easily fatigued, having difficulty concentrating, irritability, muscle tension, or sleep disturbance. Patients with general anxiety disorder, as opposed to patients with depression, tend to have difficulty falling asleep. Patients with depression have no problems falling asleep, but they tend to wake up early in the morning, 2, 3 o'clock in the morning, and then think about what's going to happen, why is my life like this, etc., etc., and then fall asleep about 5:30, only to have the alarm ring at 6 o'clock because they have to get up and go to work. The anxiety or worry or associated physical symptom that is seen in general anxiety disorder causes clinically significant distress or impairment in important areas of function. So when I get like this, I can't complete the examination, or I can't finish the task that my boss gave me. My job is at stake, and then they spiral down. This disturbance is not due to the physiological effect of any substance abuse or any medical condition, and the disturbance is not better accounted for by any other medical condition. So those are the criteria. Labs. Usually, one recommends routine labs to exclude medical conditions that could actually present like general anxiety disorder. Uh, Things like an anemia. So you're going to do complete blood count, occult infection. You're looking at the white blood cell count, electrolyte imbalance, especially calcium, may manifest with neurological dysfunction. Thyroid function test, particularly hyperthyroidism, might present initially as general anxiety disorder, but if there's a persistent tachycardia, they have lost weight unexplained, they may have bulging eyeballs, bilateral exophthalmos. The cause of the anxiety is not a psychological or mental problem, it is a hormonal problem. So you need to exclude all of the medical causes associated with tachycardia, yeah, and a feeling of anxiousness. Management, co-manage with a cognitive behavioral therapist. If there is a persistent subluxation in one particular area, you may want to stimulate the vagus nerve or the parasympathetic to reduce the overactivity in the sympathetic region. Um, the psychiatrists and the medical profession are experimenting right now with the use of vagal nerve stimulation, either internal or external devices, to help deal with general anxiety that is not well controlled on drug therapy. I think chiropractors have a much better grasp of stimulating the parasympathetic properly and allowing the body to heal itself. Cognitive behavior therapy is going to be focused on what they think, how they feel, and if we can modify the behavior in order to affect the thoughts and the emotions. And there's good evidence that cognitive behavioral therapy works for this. There is a breathing technique called cyclic sighing, where I'm going to demonstrate. So listen to the pattern. What I'm going to do is I'm going to take a deep breath, but not the best deep breath. I'm going to take a deep breath I'm going to hold it slightly and then take a deeper breath on top of that, and then gradually let that breath out in a sigh. So here is, it's 3 steps. Deep breath in, further deep breath, let it all out. Deep breath in, deeper breath in, let it all out. And you do that 3 to 5 minutes. And by this time, you've actually reduced your normal respiratory rate from about 12 to 16 or 18 breaths per minute down to one breath every 10 or 12 seconds. So if you were to count starting now, that's 12 seconds for inhalation, exhalation, and by doing this, you are inducing a hyperactive parasympathetic to get into rhythm to then dampen down the nervousness and the anxiety and the fearfulness you are feeling. And this is very good. This is emerging breathwork therapy that you could learn for yourself in case you're one of those that starts to freak out just before an OSCE or a final examination. And if it's not you, then it's something you can easily demonstrate to your patient, show them how to do this, have them do this in front of you for a minute, and say to them, go home and you do this. I would put this down on a prescription, RX, cyclic sighing, X, TID, 3 times a day for 2 weeks. Come back and see me in 2 weeks' time and tell me how you are feeling. Then there's panic disorder. Panic disorder is different. There are different criteria for a panic disorder. Panic disorder is defined as recurrent, unexpected episodes of fear or anxiety. Once again, the cause is unknown. There are separate criteria according to the Association of American Psychiatrists. The DSM-5 criteria for panic attack is A. Recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, not hours, during which time four or more out of the following 13 symptoms. Note that the abrupt surge can occur from being in a calm state, or it might be you are in a hyper anxious state. So, number one, palpitations, pounding heart, or accelerated heart rate. 2, sweating. 3, trembling or shaking. 4, sensation of shortness of breath or feeling smothered or choked. Oh, no, that's separate. 5 is feeling of a choking sensation. 6 is chest pain or discomfort in the chest. 7 is nausea or abdominal discomfort. 8 is feeling dizzy, unsteady, lightheaded, or faint. 9 is chills or heat sensation. 10 is paresthesia, which is numbness or tingling in your extremities or around your mouth. 11, derealization. This is not happening. This doesn't feel real. Depersonalization. I know this is happening, but it's not happening to me. I have this out of body kind of experience. Fear of losing control or going crazy, or fear of dying. In my green book, I have rearranged these in 2Cs, 2Ds, 2Fs, 2Ns, two S's and one P in order to help you to remember this. Once again, no labs are needed. In fact, they strongly advocate labs are forbidden for fear that you may give the patient the belief that, I think I know what's wrong with you, but just in case something serious is wrong with you, let me just rule out you're not having a heart attack or a brain fart or brain infarct or some other more serious situation. They deliberately say, do not order. You treat this confidently. They have presented with sudden onset or recurrent episodes of fear or anxiety. They have four or more out of the two C's, two D's, two F's, two S's, two N's, and one P, and you make the diagnosis comfortably. Co-managed with a cognitive behavioral therapist. There is good evidence that chiropractic adjustment either of the upper cervical vertebra or the upper thoracic region, depending on where the cluster of subluxations occur, works well. There's not been a larger a number of case studies, but just good single patient case studies written up for this. Again, co-managed with cognitive behavioral therapists. Another thing that works well for this is tapping. And tapping is the short term for emotional freedom therapy. This was first developed by a Canadian psychologist back in the late 1980s, early 1990s. And he was also a student of traditional Chinese medicine, tried to marry the two disciplines together, and found that if you tapped seven particular places in the body, all related to Chinese traditional meridia that are linked either to the heart or the liver, which are the organs according to TCM, traditional Chinese medicine, involved in the control of the emotions. There are two parts to this tapping technique. You tap starting at the top of your head, above your eyebrow, the side of your eye, underneath your nose, the chin, your collarbone, and then underneath your right or left breast. And then as you keep doing that, the other part of the therapy is to make a positive statement about yourself. And you can look this up on YouTube and you will see how to make the positive statement. The third cause of lightheadedness is hyperventilation syndrome. Hyperventilation syndrome is a syndrome that is characterized by rapid breathing, sometimes triggered by anxiety. The causes are unknown, possible psychological underlying factors. Clinical picture, gradual onset, not rapid sudden onset, which will distinguish this from panic attack or general anxiety disorder. Gradual onset of rapid shallow breathing with various symptoms. And here are the various symptoms over on the right side. General symptoms would be fatigue, nausea, sweating. Diaphoresis is a big medical word for sweating. Neurological symptoms and signs like headache, visual disturbances, dizziness, paresthesia, or actual fainting away. Cardiovascular symptoms like tachycardia, palpitations, chest pain. GI symptoms like dysphagia, epigastric discomfort, belching, dry mouth, or passing a lot of gas. Psychological disturbance like altered concentration, respiratory problems like increased breathing, chest tightening, and muscular tremors or weakness, and that sort of stuff. This is not a mental health disorder, therefore, there are no DSM 5 criteria. Once again, labs are not recommended. Treatment: refer to an urgent care if rebreathing into a paper bag is not helpful. What we do know, whatever causes the trigger, and we have a hypothesis, and the hypothesis goes like this: something triggers the nuclei found in the posterior hypothalamus that control the sympathetic system. That impulse from the hypothalamus goes down into the brainstem, affects a particular part in the brainstem, uh, and called the locus coeruleus, which now becomes sensitive to carbon dioxide, and the patient thinks they are retaining carbon dioxide, so it triggers rapid shallow breathing to blow off as much carbon dioxide as is possible. Now, if you blow off enough carbon dioxide, you're going to go from a balanced pH in your blood between 7.35 and 7.45, and you're going to become slightly alkalotic because you're going to blow off the carbon dioxide that is going to contribute when it reacts with water to the formation of carbonic acid, and therefore you are going to reduce the amount of acidity. It becomes alkaline, and then you change the pH and you change the amount of ionized calcium in the body. You change the amount of ionized calcium in the body, your nerves are going to be hyper excitable. You're going to start to feel pins and needles, and there's no extra stimulation in your fingers, and you're going to feel that. You're going to have circumoral numbness, and you're going to get worse and worse until you might pass out due to the fact that you've blown off all your carbon dioxide. There's nothing left to stimulate your respiratory centers in your medulla oblongata. And when you lose consciousness, you stop breathing for a while, and then the CO2 builds up. This is a much better way of doing this. Have them breathe into a brown paper. It doesn't necessarily have to be a brown paper bag. It doesn't necessarily have to be a paper bag. It could be a plastic bread bag. And what you're wanting them to do as they blow out the little bit of carbon dioxide, that carbon dioxide is not lost to the atmosphere. They're rebreathing that, and over the next minute or two, they will retain enough carbon dioxide to then stop the hyperventilation. And that's very easy to recognize and do. Now, obviously, some of you are going, wait a minute, doc, you claim this is easy to recognize, but doesn't look almost like a panic disorder. So what I've done here is I have a table that is going to help you to differentiate between hyperventilation and panic disorder. A trigger for hyperventilation, excessive breathing, whatever causes that. The trigger for a panic disorder is the feeling of intense fear. That is not present in hyperventilation syndrome. The onset of the rapid breathing in hyperventilation syndrome is gradual. It is sudden in panic disorder and peaks within 10 minutes. The duration of your hyperventilation syndrome episode is variable. It could be short. It could be you're doing that for the next 5 minutes. Panic disorder, it's a set time, 10 to 30 minutes. Rebreathing works like the bomb in hyperventilation, panic disorders, cognitive behavioral therapists, meds, or EFT. Any questions? We're just about halfway here. Now, if it is none of the 12 things we have talked about, has nothing to do with vertigo, has nothing to do with lightheadedness, unsteadiness or disequilibrium or presyncope, it could be hypertension. Hypertension is defined as having a blood pressure greater than 130/80. You should have learned this both in pathology, physiology, and in examination of the cardiovascular system. The levels for hypertension have changed over the last 5 years or so. In my days, and for a long while, it was hypertension was defined as having a blood pressure greater than 140 over 90. They have dropped this down in the last decade. It has taken family physicians around the world 5 years to come around to this. It is now defined as a blood pressure greater than 130 over 80. There are two categories of hypertension. One is unknown. 95% of all patients of hypertension, we don't know the cause. And then the small percentage, 5%, is secondary in nature. And we will look at specific labs or physical exam findings that when you find this in addition to the elevated blood pressure greater than 130 over 80, you know that this hypertension is secondary in nature, and that has a different management to primary or idiopathic or essential hypertension. Clinical picture, hypertension is usually asymptomatic, but some patients may present with the following: dizziness, irregular heartbeat, nausea, vomiting, fainting, low blood pressure. 20 to 30% of patients with hypertension may experience dizziness. They could complain of shortness of breath. They could complain of headaches that are worse in the morning. When you examine them, in addition to having the elevated blood pressure, you can look in the back of their eyes, do a fundoscopy, and you will see one of four possible changes that when you see this, you go, yep, your hypertension is not just in the last couple of months in which you've had dizziness or headaches. You have had sustained high blood pressure probably for the last 5 years, because I've seen these hypertensive changes in the back of your eye, and we'll go over those shortly. You may examine the abdomen and hear a bruit, especially if it is a midline, epigastric bruit off to the midline, either 1 inch to the right or 1 inch to the left. You're hearing whoosh, 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 whoosh. This may be indicative of an underlying unilateral renal artery stenosis. You may see the obvious bilateral exophthalmos that occurs with Graves' disease, which is one of the uncommon causes of hypertension. You may see the classic moon face features of Cushing's disease, which is another uncommon cause of secondary hypertension. Labs, you're going to order CMP, thyroid function tests, vanillyl mandelic acid, to exclude some of the more common causes or uncommon causes of secondary hypertension. The asterisk actually refers, if you were to look at the not the PDF version of this presentation, but look at the traditional version. In the notes down below, you're going to see signs and symptoms of Cushing's, unilateral renal artery stenosis, pheochromocytoma, hyperthyroidism, hyperaldosteronism, otherwise known as Conn's disease, or coarctation of the aorta. Management. Co-manage with a medical doctor. Now, remember when we talked about co-manage, it means you have a role as a chiropractor. The medical doctor has a role as a medical doctor. What is your role in the management of hypertension as a chiropractor? One, if the patient is overweight, you have them lose some weight. If the patient is smoking, you have them stop smoking. You can have the patient modify their diet, in particular, decrease the amount of salt, because for essential hypertension or primary hypertension, it is due to an increased sensitivity to the amount of salt in the blood, and if we can cut that down, we can bring the blood pressure down. So in addition to non-adjustive techniques, like I just mentioned, that's your role. Also, if you are familiar with the NUCA technique, because this article that appeared in the Journal of Hypertension many years ago, many years ago, 2007, uh, written by a chiropractor, and it was originally two medical doctors and George Bacris, and there's a big tick next to his name, wasn't originally involved in this research. He was the editor of the Journal of Human Hypertension at the time, reviewing the paper pre-publication, did not believe that an atlas vertebral realignment can bring down the blood pressure by 10 to 15 points in this pilot study that the chiropractor and the medical doctor were involved in. So he brought in an epidemiologist to look at their methodology. They went over their data in great detail, was convinced that chiropractic care could have a definitive role in the management of patients with hypertension. And because of the work he contributed post the research or and pre publication, he then put his name out in front of this. Um, not it's probably by design, or it could have gone. They arranged the names in alphabetical order. Bacchus comes before D, which comes before M, and then K. No, A should have, no. There must have been some other reason than he just wanted his name out in front because he was the editor of this journal. Whatever is the reason, this journal article was published in this internationally respected journal on hypertension, and establish once and for all, at least in my mind, that chiropractic care does play an important role in the management of a patient with hypertension. It was in 2007 when Dr. Shreve, a senior colleague on campus, showed me this paper. My wife at the time was suffering from severe hypertension. Post a dental cleaning, her blood pressure shot up to 180 over 120. She was put on eventually three powerful antihypertensive drugs. I showed her the paper. I said to her, I have this good colleague that does a specific upper cervical adjustment called NUCA, and recommended her to go to see Dr. Shreve. And my wife is now off of those three powerful meds, and she's only on one beta blocker for her hypertension for the past 10, 15 years. It works. And that's my recommendation for chiropractic from a medical perspective. Any questions? All right, let's look at some of the lab tests that we talked about, used to confirm that this is an infection or this is a biochemical. There were just few tests that we talked about. One was a comprehensive metabolic panel. We talked about one of the causes of presyncope was hypoglycemia. This would involve the comprehensive metabolic panel. We talked about Cushing's and Conn's disease as causes of secondary hypertension. Comprehensive metabolic panel finding hypernatremia and hypokalemia is going to be seen in Cushing's syndrome and in Conn's disease. Thyroid function tests we talked about as being needed to confirm hyperthyroidism. Hyperthyroidism is one of the causes of hypertension. One of the uncommon causes of postural hypotension would be a drop in the blood pressure that is associated with myxedema. Remember, myxedema causes your pulse to slow. It is going to cause hypotension, which might then trigger this feeling of unsteadiness. Thyroid stimulating hormone. Remember the uh, negative feedback loop. So if your T3, T4 are low, your TSH is going to be high in myxedema. If your T3, T4 is high, it would be low in Graves' disease. Now, throughout the rest of the course and your examinations, even though we would have, and the other test we're going to be ordering is vinyl mandelic acid. If we thought that pheochromocytoma was the cause of the secondary hypertension. Remember, VMA, vinyl mandelic acid, is a breakdown metabolite of norepinephrine, which will then be spilt out into the urine. And it's indicative of pheochromocytoma. It doesn't tell you whether the pheochromocytoma was bilateral or malignant or more likely to run in families, because remember, pheochromocytoma, the 10% tumor, 10% are bilateral, 10% runs in family, 10% could be malignant. Any questions? All right, let's then go and look at some of the physical signs and tests that we talked about directly or indirectly when we discuss these 13 conditions that could present with dizziness. And remember, this is in alphabetical order. It's not suggesting that this is more important than the very last one. Abdominal bruit. We're looking for an abdominal bruit that is in the epigastric region, but over one renal artery. If you hear abdominal bruit, when you put your stethoscope over the area in the midline there between the xiphoid process and the umbilicus, and you hear a bruit, that's a bruit associated with the aorta, usually an abdominal aortic aneurysm. 1 inch to the right or left, that would be over the renal artery. That is a direct branch coming off from the abdominal aorta going to each kidney. And if you hear a whoosh, 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 lateral to the midline in a patient whose blood pressure is high and who is a younger person, then you're probably dealing with unilateral renal artery stenosis. You send this patient off to a cardiologist for them to then uh, confirm your diagnosis, and they will then send the patient off to a vascular surgeon or a renal specialist for further treatment. Um, yeah, if the bruit is heard below the umbilicus, uh, 1 inch down, 1 inch out, that is over the common iliac arteries. Remember, atherosclerosis is going to be worse where main arteries are going to bifurcate. So where the common carotid artery splits off into the internal and external iliac arteries might be narrowed. This patient might present with intermittent claudication rather than with hypertension. So blowing sound, best heard listening 3 centimeters, just 1 inch out, 1 inch and a bit. And this is one of the secondary causes of hypertension. Blood pressure measurement. I know you have learned this. I'm not too sure how important the clinic places on this, but your role as a primary care physician like me is that we need to be screening for treatable diseases, and hypertension is one of those that we can treat. Both you and I can treat well. Um, You may get this in your clinic entrance examination. I know in the past some of the examiners have insisted on let's check and see how well chiropractic students can take blood pressures. The patient needs to be rested, needs to be seated with a back support. I can tell you on the count of my right hand, since I was attending the clinic as a patient, 2003 was the first time that I attended uh, the clinic as a patient, and they stopped seeing me when I turned 70 because they found out that I was now elderly and I should be treated properly like the Medicare patients, and students are not allowed, for whatever reason, to treat older people. I'm not too sure then if you're not allowed to treat older people, where are you going to get that experience in dealing with old people like myself? In the umpteen times my blood pressure was checked, which was usually every 3 months, none of my students had me sit on a chair with a back support. There are, in fact, no chairs like that in many of the adjusting rooms. You need to be seated with a back support. If not, that sends your blood pressure in the wrong direction. The arm that you're testing with putting the cuff should be resting on the table or the arm of your chair, not at the side, hanging down at the side of your body. The cuff should be placed 2 to 3 centimeters above the cubital fossa. You should inflate the blood pressure cuff until it is 30 millimeters above the palpatory systolic pressure. So you're going to feel the right rate. This will okay. Feel the left radial pulse with your left hand. You're going to pump this up, and then you feel that perhaps around 120, 130, your radial pulse disappears, and then you're going to put that up 30 millimeters above that palpatory systolic pressure. Then you're going to place the bell, not the diaphragm, over the brachial artery in the cubital fossa. And you're going to slowly deflate the cuff 1 to 2 millimeters per second. And as you slowly deflate the cuff, you're waiting, you're hearing nothing, and then you're going to start to hear whoosh, whoosh, whoosh. And you note the level at which the first whoosh, whoosh is heard. You continue to listen, that whoosh, 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 whoosh will all of a sudden in most patients disappear, and then you note at that point where it disappears. So you're going to note the cough sounds, one, where it appears, and two, where it disappears. Now, occasionally, in some people, it continues to be heard long after. So you're going to have to start over again, and you're going to confirm whoosh, whoosh, at around maybe 130 or 140, and then at around 80, it changes slightly. So instead of whoosh, 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 it would be slightly muffled, and then you will continue hearing that muffled sound until it's zero. So what you do at that stage, you go back and you choose the point at which the sound becomes muffled. Since when you listen to it, it doesn't disappear out completely. And then you put that as your systolic and your diastolic pressure. Remember, you need to repeat this on the opposite side. Why? Because occasionally you can have something called coarctation of the aorta, and on depending on where the coarctation is, the blood pressure in one arm might be different in the other arm, or it could be an even less common condition called subclavian steal syndrome, in which there's going to be a difference between the two blood pressures. And anytime you have one blood pressure in one arm being greater or less than 10 millimeters compared to the other arm, that is something that you should be concerned about. You would refer that patient to a medical doctor for possible, if the patient is hypertensive, ruling out coarctation of the aorta or subclavian steal syndrome. This is an important feature here in my class. And therefore, you could be asked about the placement of the arm, the placement of the cuff. You could be asked about how much higher beyond the palpitary systolic should you increase the blood pressure. You could be asked about, if it doesn't disappear completely, where do you put your diastolic pressure? And remember, you're going to put your diastolic pressure when it goes from whoosh, 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 whoosh to it becomes muffled. We talked about the Dix-Hallpike maneuver, a test for confirming that the patient has benign paroxysmal positional vertigo, because sometimes when they come to see you, all they're coming in with is the history. When I turn my head to one particular side, it triggers this. So you might be required to trigger this yourself and explain the patient, like with any other test, especially if you get asked to do this in boards part 4. You'll have to tell the patient what you're about to do, and what you're about to do might trigger that nasty episode of the room spinning. Do you mind if I do that? You have to get permission. If the patient says no, then you have to base the diagnosis off of the history and document that the patient, for fear of triggering one of these nasty episodes, did not allow you to do the Dix-Hallpike maneuver. So after you've gotten permission from the patient to do this test, make sure the patient is seated on the exam table with their legs extending over the side, that you stand behind or to the side of the patient to provide support. You're going to turn the patient's head 45 degrees towards the ear that is being tested. You're going to rapidly assist the patient to lie back such that the head hangs over the edge of the table. You're going to then extend the head further by 20 to 30 degrees, and then look at the patient's eyes for 30 seconds to a minute to see if their eyes are dancing. Remember, it's going to undergo horizontal movement from ear to ear. Ask the patient to report any feelings of vertigo. Slowly return the patient to the original position. And if there was sudden onset of nystagmus and vertigo when the affected ear was facing downwards, then this is confirmatory for benign positional paroxysmal vertigo. If turning the patient's ear to the right side does not do that, then go over on the left side and repeat the same procedure, except you will be turning the patient's head 45 degrees towards you on the left side. Okay. Then there's a test for disequilibrium. We didn't talk about this because this is a test for cerebellar dysfunction, but remember when we were screening the patient for vertigo, and patient was complaining of dizziness, and we were concerned about, is this patient having early stages of vertebral artery dissection? I said to you, there are a number of D's that you're going to test for: double vision or diplopia, dysarthria, disequilibrium. This is a test for disequilibrium. The name of this test is dysdiadochokinesia, one of the longest medical words in the medical dictionary. Dis means dysfunction. Kinesia has to do with movement. Dia means both. So there's a dysfunction in doing movement on both sides, and doko means alternating. So the word dysdiadochokinesia is defined as difficulty in performing rapidly alternating movements. You've asked this patient to go from show me your palm, show me your fingers, show me your palm, show me the back of your palm, and do that rapidly. Usually done in the hands. You can do this with the palms facing down on the thighs and ask the patient to tap the thighs with their palms, turn this over, tap the thighs with the back of their hands, and do that rapidly. Uh, Being unable to rapidly pronate and supinate the hands is evident of dysdiadochokinesia, which says this is cerebral ataxia, multiple sclerosis, or it could be brain damage caused by chronic traumatic brain injury. Hypertensive retinopathy. Remember, I said you can tell if this patient's hypertension has been just a couple of months or has been there for some time by looking at the back of the eye. So we're looking at the retina through the pupils with the aid of an ophthalmoscope. You're going to make sure you have the patient in as dark a room as possible. They're going to be focused in the corner of the room. You're going to be looking in one eye. You're going to start with their right eye, and you're going to be using your right eye to right eye, switch over left eye to left eye. There are a number of grades according to the Keat-Wagner grading system. Grade 1 is where the red blood vessels change their red color to either copper, which is a brownish red, or when it gets severe, silver strands. This is grade 1 hypertensive retinopathy. If the blood pressure has been there for much longer and much higher, there's going to be AV nipping, arteriovenous nipping. The artery is going to be crossing over the vein, and if the arterial pressure is high, it's going to compress the vein where it is being compressed, and that's called AV nipping. Third, and you can see that clear here, flame hemorrhages. Let's use the pointer here for this. Here are the flame hemorrhages, these blotches. And then as the hemorrhage resolves, remember these are blood vessels. The tissue underneath the blood vessel is going to be deprived of oxygen. That tissue is going to die and is going to leave white scars there. And these are called cottonwood exudates. They're not exudates per se. They're just patches of loss of demyelination in the neurons that are being deprived of oxygen. And then the fourth, you're looking at the optic disc to see if the optic disc is swollen. And grades 1, 2, 3, and 4 increase in the number, increase in the severity of the hypertension. And usually the papilledema is bilateral. And when you have bilateral papilledema, your blood pressure is going to be anything above 180 over 120. And this might be called malignant hypertension, or it might be viewed as a crisis, and this could be called hypertensive crisis. This is nystagmus, and this is a patient who is being asked to look over to the right, and looking over to the right triggers this back and forth movement. This is nystagmus. Nystagmus is defined as the rapid, involuntary, repetitive movement of the eyes. It may be horizontal, as in this. It could be vertical, which is up and down. And I've seen both of them. I've never seen a rotatory nystagmus, and I couldn't get a nice gift to show me the eyeballs going around and around in the same direction, to the right, to the right, to the right. It must be disconcerting or hypnotic. It may affect one eye or both eyes. And here are four conditions that we talked about: multiple sclerosis, Meniere's disease, benign paroxysmal positional vertigo, and vestibular neuronitis. And you can tell the difference between the two depending on what other signs and symptoms are associated with the nystagmus. Here is past pointing in the picture above. The professor has said to the patient, I'm going to, he's just demonstrating, I'm going to ask you to touch my finger like that, and then I'm going to ask you to touch your nose. And he puts back his finger and he says, go ahead. Touch my finger, touch your nose, touch my finger, touch your nose. And he's looking for the patient missing the doctor's examining finger or missing pointing at her nose. She slides off and touches her cheek. And the presence of past pointing is indicative that you have a problem with your cerebellum. The other name for past pointing is dysmetria. Dys means to do with difficulty. Metria has to do with meter, distance, difficulty in working out or calculating the exact distance. It could be overshooting, goes beyond the target, or undershooting, they don't reach the target that they're pointing, being asked to touch. So instruct your patient to touch your finger and touch his nose, and do that rapidly with both hands. Multiple sclerosis, cerebellar disease, or alcoholic intoxication. This is could be part of the physical examination in the ER or at the roadside by a cop that says, Mr. Clemens, step out of the car, please. Could you walk towards me by keeping your feet on the white line? And then come towards me and touch my finger, touch your nose, and then get you to blow into his breathalyzer, and then you're booked for drunken and disorderly driving. Next would be checking for a radiofemoral delay. And what you're looking for is an asynchronous pulsation between the right radial artery and the right femoral artery. So you palpate the right radial artery with your left hand, then palpate, find the femoral artery in the right groin, and if you want to be proficient and not poking around feeling in inappropriate places where the hell is the femoral artery is, you palpate where the ASIS is, anterior superior iliac spine. You palpate where the pubic tubercle is, not in the midline. That's the pubic symphysis, 1 inch off, lateral to the midline with the pubic tubercle. Draw an imaginary line between the two. Divide that line into half, and the mid point there, you put your finger right there, and you are slap bang on the femoral artery. And you note whether the radial pulse, right radial pulse, is beating boop, boop, in time with boop, boop, the femoral artery. In radiofemoral delay, what you're looking for is a disconnect between the two. And this is due to the extended time the blood is going to take from traveling from the heart to the abdominal aorta through its branches in a patient with coarctation of the aorta. Remember, coarctation of the aorta commonly occurs post-ductal. Ductal has to do where the ductus arteriosus is. The most common site is post-ductal. And then the blood passing into the descending thoracic aorta and then the abdominal aorta is markedly reduced because of this congenital narrowing. In order for blood to get from the heart to the arch of the aorta into the abdominal aorta, it has to go through subclavian artery, first branch of the subclavian artery going down, internal thoracic artery. One of the terminal branches of the thoracic artery would be the superior epigastric, which will then anastomose with the inferior epigastric, and then eventually come back to the the external iliac artery, or it goes from subclavian artery, internal thoracic artery, anterior intercostals, posterior intercostals, and into the descending part of the thoracic aorta. And that took me some time to explain, and that is how you're going to get a delay in the radiofemoral pulse. So here is the visual presentation. Here is the coarctation in the commonest position, postductal. That's the ductus arteriosus. Blood is going to be diminished going through this portion of the thoracic part of the descending aorta, and the blood has to then go up into the left subclavian artery, down the internal thoracic artery, through the first 6 anterior intercostal arteries, which will then anastomose with the posterior intercostal arteries come off of the thoracic aorta, the descending part of the thoracic aorta, and then blood gets back there, or through an even longer circuitous fashion. One of the terminal branches here, superior epigastric, will then fuse with the inferior epigastric artery, which is then coming off of the external iliac artery just before it passes under the inguinal ligament to become the femoral artery, which you're going to then palpate. Any questions? If there are no questions, here's your homework for next week. You're going to read the next chapter in Chiro Essentials Differential Diagnosis. You're going to download the appropriate words, review the appropriate words, come prepared to have a discussion next week. If there are no questions, we can either stop here today, or if time permits, we can then play another game of 20 questions, think aloud. Kathy, the case information is in the PowerPoint, this PowerPoint presentation, below in the notes accompanying this particular one. And you know the routine, how to play this if you want to have fun with the students. Okay, that's all for now.